On behalf of Adley Oncology, I would like to welcome guest speaker of today's webinar, Dr. Akansha Garg, as well as Dr. Ankit Riyani. I would also like to welcome moderator, Dr. Amit Khurana sir, all the discussions and the participants. So in the today's webinar, we'll be covering two topics. One is perioperative management of anticoagulants, which Dr. Akansha Garg will be taking. And the second topic is thrombotic thrombocytopenic purpura, new advances, which Dr. Ankit Riyani will be taking. So before we proceed, I have a couple of slides to present to just showcase the recent developments in Adley Oncology. The first development is the launch of Adaxet OS, that is methotrexate oral solution. This is first time in India. It is bioequivalent to tablets in fed and fasting condition. It improves treatment convenience, accuracy and easy dosing, trusted efficacy in every ml. It is palatable. The taste is raspberry, which I am sure the pediatric patients will like, and it has uniform drug dispersion. So this product is unique in a sense that it is going to address the long pending issue of pediatric patients who are unable to swallow pills. We are very proud that we have been again acknowledged by Forbes Asia as the fastest growing company in Asia under $1 billion company. So this is the fourth consecutive year Forbes has acknowledged our contribution to the oncology industry. We have been also recognized as the top 10 pharma manufacturers by Indian Pharma Manufacturing Magazine. We have a wide range of hemato-oncology products, right from azacitidine injection to azacitidine oral, acalabrutinib, fludarabine, pomalidomide, carfilzomib, bortezomib, dasatinib, nilotinib, imatinib, busulfan, peglaspergines, plerixafor, and eltrombopag. Apart from this, we are in a very advanced stage to collaborate with couple of MNCs to bring in some novel molecules which is not available in India. In Adley Oncology, patient first is our guiding principle. So we are among very few companies who are working on NDDS formulations. We have a unique patient support program wherein we try to support each and every non-affording patient. So till date, we have not denied treatment to any single patient across the country. So if you have any patients who is non-affordable, then Adley will be in the forefront to support the patient. We are doing a lot of scientific activities for the awareness of patients, and the unique thing about the company is the API. So right from the formulation, API is also in-house, that ensures cost effectiveness as well as the quality of the product. Thank you so very much. Now I will hand over the session to Dr. Dr. Amit Khurana sir, please. Thank you.
Thank you, Mr. Ashutosh. Can you please unshare the screen once? Yeah,
Yeah.
thank you. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today we have got two guest speakers. The first one is Dr. Akansha Garg from Ahmedabad, and the second one again from Ahmedabad, Dr. Ankit Riyani. Our first guest speaker, Dr. Akansha Garg from Ahmedabad, is going to lecture us on perioperative management of anticoagulation. And our second guest speaker, Dr. Ankit Riyani from Ahmedabad, is going to lecture us on thrombotic thrombocytopenic purpura, new advances. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Adley Oncology and very well managed by Perfect Square. I thank Mr. Ashutosh Shukla and the team from Adley, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for the day, Dr. Akansha Garg from Ahmedabad and Dr. Ankit Riyani again from Ahmedabad. All our discussants who are themselves very eminent hematologists, and you participants for spending a Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 7th of December 2025 from 11:30 am Indian Standard Time, we have Colonel Dr. Rajan Kapoor from RNR Army Hospital, Delhi, speaking to us on NTPA for immunothrombotic syndromes. Let me introduce our discussions for the day, and there are galaxy of them here displayed in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day for very eminent hematologists, hemato-oncologists, as well as medical oncologists all across the country. Some more over here. Well, so these are our discussions for the day. And now it's time to introduce our first guest speaker for the day. We have with us no other than Dr. Akanksha Garg from Ahmedabad. Dr. Akanksha Garg is known to us, to all of us. She's a very academician and she regularly attends all our MSG meetings. It's my formal duty to introduce Dr. Akanksha Garg again to all of you. Dr. Akanksha Garg is consultant hematologist as well as bone marrow transplant physician at Zydus Hospitals and Zydus Cancer Center, Ahmedabad. She is ex-associate professor at Department of Medical Oncology and Hematology at AIIMS Jodhpur from the year 2022 to 2023. Ex-assistant professor, consultant hematologist and BMT physician in the Department of Medical Oncology, GCRA Ahmedabad from the year 2018 to 2022. She did her MBBS from very prestigious Maulana Azad Medical College 2003 to 2009, followed by MD in Pediatrics from Lady Hardinge's Medical College in the year 2019 to 2012, followed by PDCC in Hemato-Oncology from the prestigious again Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow from the year 2013 to 2014, followed by DM in Clinical Hematology again from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow from the year 2015 to 2018. She has also done observership in adult stem cell transplant from Institut Gustave Roussy, France in the year December 2018, followed by observership in pediatric stem cell transplant from Universität Klinikum, Germany in the year January 2020. Again, she has also done the observership in stem cell and cellular therapies at the Department of Hematology, King's College Hospital, London, UK in the year 2023 November. She is also the member of SIOP, PHO chapter, IAP, ISHBT, ISBMT, ESMO, and EHA. She has numerous publications in peer-reviewed articles in both national and international journals. Her special areas of interest include stem cell transplantation, myeloma, lymphoma, acute myeloid leukemia, as well as hemoglobinopathies. Today, she is with us and she is going to lecture us on perioperative management of anticoagulation. Well, thank you so much. I stop over here. Over to you, Dr. Akanksha Garg.
Thank you, Dr. Amit, for the kind introduction. I hope my slides are visible.
Can you please move it in full screen mode, please?
Yeah.
Perfect. Please go ahead.
Yeah, so at the outset, I'd like to thank the Mumbai Hematology Group and Dr. M.D. Agarwal sir for giving me this opportunity. So I will be talking about the perioperative management of anticoagulation. And we all know that, for patients who are undergoing surgery and to have an optimal outcome post-surgery, the role of the hematologist is extremely important. And the main goal here is to avoid both the bleeding and the clotting events. So just, to have a delicate balance between the two so that you can have an optimal outcome. So in my talk, I will basically be covering the major factors which determine whether we need to bridge the patients on both warfarin or if the patient is on direct oral anticoagulants, what needs to be done, how we need to interrupt the anticoagulation, do we need any bridging therapy? And also in the end, I'll also be covering about the antiplatelet therapy, how we usually deal with patients who are on antiplatelet therapy who are undergoing surgery. So it is mainly a stepwise approach when we deal with such patients. First is to basically estimate the bleeding risk in these patients. So what kind of surgery is going to occur, whether it carries a high bleeding risk or a medium bleeding risk or a low risk. Second is to estimate the thrombosis risk, whether the patient requires, the continuation of the anticoagulation, because if we interrupt it, the patient is exposed to higher thrombotic risk. Step 3 is to determine the time of the anticoagulant interruption. So if the patient is at a high bleeding risk, when do we stop the anticoagulation, and whether to bridge the patient with a parenteral anticoagulant or not. So I will be discussing these stepwise. So when we talk about the perioperative bleeding risk, there are various types of surgeries and they have been divided into 3 groups. So high bleed risk surgeries, where the 30-day risk of major bleeding is more than 2%. So any major surgery which requires extensive tissue which can lead to extensive tissue injury, any cancer surgery, any major orthopedic surgeries, urologic GI surgeries, colonic polyp resections, cardiac surgeries, spinal surgeries, neurosurgeries, any epidural injections or anesthesia required. So these are all the high bleed risk surgery. The low to moderate bleed risk surgeries include arthroscopy, any lymph node biopsies, coronary angiography, endoscopies, if there is any cholecystectomy planned, hernia repair, bronchoscopy, and so on. So these surgeries carry a risk of 0 to 2% of bleeding. And at the extreme other end is the minimal bleed risk surgeries, which have a absolutely zero risk of bleeding. So dermatologic procedures, skin biopsies, any excision of skin cancers, if there are any dental procedures or any ophthalmologic procedures like cataract surgeries, or placement of pacemaker or a defibrillator device implantation. So these are the various categories of bleeding risk. There have been previous studies published, but the main important meta-analysis, which was published in the Circulation Journal in 2012, that basically showed that if you do bridge the patient with a parenteral anticoagulant and you stop the oral anticoagulant, then there is going to be a 3 to 4-fold increase in major bleeding in these patients. For certain invasive procedures, major bleeding is usually rare. So these are mainly the ones which I spoke about in the minor bleeding risk group, that is dental extractions, pacemaker placement, and cataract surgery. So these were all, they have been shown in the various studies that the risk is less than almost 0% in most of these. This was the dentist study where dental extractions were done on patients who were either on direct oral anticoagulants or warfarin. And it was seen that in both the groups, there were no major bleeding in most of the cases who underwent extractions. Then important landmark study was the bruise control study, where patients who were on warfarin and they required a pacemaker placement or a intracardiac device, they were randomized to either continue warfarin, or the second group was that the warfarin would be interrupted and the bridging would be done with the help of LMWH, that was enoxaparin at 1 milligram per kg BD, starting within 24 hours post the procedure. And the results were astonishing because it was seen that the incidence of the pacemaker hematoma was higher when the warfarin was interrupted and there was a bridging given, that is with the LMWH. So it was 16% in the bridging group as compared to 4% in the patients who just continued with the warfarin. Then the second study, which was the bruise control 2 study, this studied the DOACs, the use of DOACs in these patients who were undergoing the pacemaker placement. And there were almost more than 600 patients who were randomized to either continuing the DOAC or interrupting it for 1 day preoperative. And you can see that in both the groups, the risk of transient ischemic attacks or the hematoma was similar. So it didn't make much difference whether you would continue or interrupt the DOAC in these patients. Then this was an important landmark study, which was an open label randomized control study and double blinded, which was the bridge study, where the patients who were receiving warfarin, whether for atrial fibrillation or for any mechanical valve, heart valve, they were randomized to either receive bridging dalteparin or a bridging placebo. And you can see here that in the patients who were given the bridging vis-a-vis the patients who were not bridged, there was not much difference in the risk of arterial thromboembolism or stroke. So it was found that the no bridging group, it was non-inferior to the bridging. But on the other hand, the major bleeding that occurred more in the patients who were given a bridging. So no bridging was superior to bridging in terms of bleeding incidence. So what was the better group? According to this study, that was the no bridging group. Now, this particular study was the Periop 2 trial. It was similar to the bridge trial, and what it showed was that in similar group of patients, they were either taking the anticoagulation for a non-valvular AF or a mechanical heart valve, and the incidence of thromboembolism and major bleeding were almost similar in both the groups. So this was all about the risk of bleeding and how to classify the bleeding risk in the patients. What about the thrombotic risk classifications? So this is basically, according to the groups of patients who receive long-term anticoagulation. So we know that any patient with a mechanical heart valve would receive a long-term anticoagulation with the either warfarin. And if the patient has a non-valvular AF, then those patients may be either on warfarin or on the DOACs. And thirdly, the patients who have a venous thromboembolism. So accordingly, they have been divided into a high-risk category where the risk of arterial thromboembolism is more than 10% per year, or a VT risk of more than 10% per month. So what are these high-risk groups? Mainly the mitral valve replacement, which has been done in the patients, and they have major risk factors for stroke. So what could be those factors? One could be increasing age, patients having heart failure, patients having hypertension, diabetes. So those are risk factors for stroke. If a patient has a caged ball or a tilting disc valve, so these are special type of valves for both mitral and aortic replacement. And if the patient has a recent stroke in less than 3 months ago. In the patients who have non-valvular AF, there is basically the score called as the CHAD-VAS score. So this is a score which helps in estimating the annual risk of thromboembolism in patients who have non-valvular AF. And that is how we decide what is their risk for thrombosis. So I will be discussing the components of the CHAD-VAS, but just to for your idea, if the score is above 7, then they are categorized into a high risk for thrombosis. And third is the venous thromboembolism group. So recent thromboembolism less than 3 months. If the patient has any severe thrombophilia like deficiency of protein C, protein S, homozygous factor V leiden, APLA syndrome, or the patient has an active cancer associated with high VTE risk. So these three are the high risk groups. Moderate is where the risk is between 4 to 10% per year, risk of arterial thromboembolism or venous thromboembolism. So these are the criteria: mitral valve without major risk factors for stroke, a bileaflet AVR, AF, patients with AF having CHAD-VAS score of 5 or 6, and in the VTE group, if the VTE has happened in the 3 to 12 months, past 3 to 12 months, they have non-severe thrombophilia. So these are the moderate group, and the others are the low risk. So to illustrate all these points, I'll discuss few cases. So case 1 is of an 80-year-old female with a history of hypertension, diabetes. She has a non-valvular AF, and the patient has had no history of PIA, stroke, or bleeding. This patient is on warfarin and is well controlled, having well-controlled INRs. Now she's planned for an elective major abdominal surgery. So step 1 was to estimate the bleeding risk. So major abdominal surgery is basically your high bleed risk as per the table that I had shown earlier. So patient has a high bleeding risk. What about the thrombosis? So this is a case of non-valvular AF. So we will look at the CHAD-VAS score. For this particular patient, she has hypertension, she's female, age is more than 75, she's diabetic. So her CHAD-VAS score was coming around 5. So 5 falls into the moderate thrombotic risk. So I told you the high risk ones are the ones who are having a CHAD-VAS score of above 7. So 5 and 6 is thrombotic risk moderate. So she has a thrombotic risk which is moderate and a bleeding risk which is high. So how do we manage her? She's on warfarin. So as for the key recommendations, patients who are receiving the warfarin and who require interruption prior to surgery, the warfarin has to be stopped 5 days prior to the surgery, and you can restart it within 24 hours following the surgery. For most of the cases, so this is something which we need to remember, patients on warfarin, unless they have a very high risk of thromboembolism. So the upper 3 criteria, the mitral valve, the caged valve, tilting valve, or patient is having CHAD-VAS score of 7 or above for the non-valvular AF, or a recent VTE or severe thrombophilia. So those are only the patients where you would give the heparin bridging if the patient is on warfarin. For minor procedures, most of the patients, you can just continue the warfarin. There is no need for interruption. If there is a bleeding, slight bleeding, then you can use some hemostatic agents like oral tranexia, desmopressin, and so on. For, like I discussed, for the warfarin, basically patients who are at very high risk of thromboembolism, those are the only ones where we would give a bridging. So then how the bridging is decided is according to the bleeding risk. So if the patient is having minimal bleed risk, like I discussed in the previous slide, you just continue the warfarin. If there is a low to moderate bleed risk, that is all those surgeries where the hernia repair, or the patient is required for endoscopy, or there's a biopsy. In those cases, you will bridge with the LMWH, and most of the times the LMWH is started at day -3 prior to the procedure, and you stop it on the morning prior to the procedure plan. The other option for the for the LMWH, basically you can use either enoxaparin or a dalteparin. What about the resumption of the anticoagulation post the procedure? So for the warfarin, you can start within 24 hours. If the patient has a high bleeding risk, for the first 24 hours, it may not be possible that you can give a LMWH full blown. So in those cases, you can give low dose LMWH like 40 mg OD and so on. And once you achieve the hemostasis, which is usually by the next 48 to 72 hours, then you can put the patient on complete the therapeutic doses of LMWH till your warfarin starts to take action. Now coming back to the case that I discussed. So her CHADVA score was 5. She was having moderate thrombotic risk and high bleeding risk, because it was a major abdominal surgery planned. So according to all these recommendations and whatever I discussed, she was mainly planned to stop the warfarin 5 days prior to the surgery. There was no need for bridging because this is a moderate thrombotic risk. She was not in the high thrombotic risk group. And after the surgery, on the evening, you can start the warfarin for this particular patient. So that is how her anticoagulation would be monitored. Now, another case, this was of a 78-year-old male with pulmonary hypertension, congestive heart failure, aortic stenosis, for which an AV replacement was done 5 years ago. This patient is taken warfarin. Now, this patient was planned for a nephrectomy because of a recently diagnosed renal cell carcinoma. So again, we need to estimate what is the risk of the thromboembolic event of the anticoagulation and whether the patient needs to be bridged. So again, we look at the bleeding risk and thrombotic risk. This is basically a table which is showing what are the major factors affecting the thromboembolism in patients having mechanical valves. I won't go into the details. So for this particular patient who is on AV valve, this patient fell into the high risk category for thrombosis. And bleeding risk, because it was a cancer surgery, we have seen cancer surgeries are falling into the high bleeding risk groups. So thrombotic risk is high, bleeding risk is high. So our plan would be to give a bridging with LMWH. Even though the bleed risk is high, but the thrombosis that takes precedence over the bleeding risk. So we will have to give an LMWH. So warfarin would be omitted 5 days prior to the procedure. Preoperative bridging would be done with the help of LMWH. And this would start at preoperative day -3. And last dose would be given on the day -1 morning. That is 1 day prior to the surgery. Warfarin can start within 24 hours after the surgery at the usual dose that the patient was taking. And post-operatively, because the bleeding risk is high, you can start with a low dose LMWH. So 40 mg OD or dalteparin 5,000 units subcut once a day within the 24 hours after surgery. And once you have a hemostasis, then 48 to 72 hours after the surgery, you can start with the full-blown LMWH. Now, the third case is for patients who are on direct oral anticoagulants. So a 58-year-old male with recent history of DVT 6 months back on apixaban. So 6 months of ago DVT, this patient will have a moderate thrombotic risk. The patient is planned for colonoscopy because there's a history of pre-malignant colorectal polyps in the family, and also probably would undergo a polypectomy. Create clearance is above 50 ml per minute. So what would be the anticoagulant management? So moderate thrombotic risk. Bleeding risk is high because the patient is planned for polypectomy. Now, what about the DOACs? So what is the consensus on the management of patients who are undergoing surgery and who have been taking long-term DOACs? So this was the PAUSE study. This had almost more than 3,000 patients who were taking the DOACs. So some of them were on dabigatran. It was a mixed population. Some were on apixaban and also on rivaroxaban. So the authors here, they basically devised a protocol where they would stop the anticoagulant depending on the bleeding risk of the surgical procedure. So suppose the patient has a high bleeding risk procedure, major abdominal surgery, cancer surgery, then in most of these DOACs, you would stop the DOAC 2 days prior to the day of the procedure. And when to resume is usually after 24 hours post the procedure. Now, if the bleeding risk is low to moderate, then in those cases, you can just stop it 1 day prior. So the total interruption for low bleeding risk is 2 days, that is 1 day prior to the surgery and on the day of the surgery. For high bleeding risk procedures, it is total interruption of 4 days, 2 days prior to the surgery, on the day of the surgery, as well as 1 more day post surgery. So total 4 days of interruption. Dabigatran, it basically, it has a renal clearance. So it also depends, the stopping the drug also depends on what is the patient's creat clearance. So the patient has a creat clearance of less than 50, then the total interruption for dabigatran is 4 days prior to the surgery, on the day of the surgery, and then 2 days post surgery. So this becomes almost 7 days. And also rivaroxaban is similar to apixaban. So what were the results of this study? What they found was that patients who were on DOAC therapy and the interruption is done for a particular surgery or procedure, then most of the times you do not require any heparin bridging because there is no difference in the major bleeding or the arterial thromboembolism in these patients. And there are usually both the rates are quite low. So for the DOACs, there is no need for heparin bridging. So heparin bridging is only required for patients taking warfarin and who are on high risk of thrombosis. So this is what is followed. This is basically, for the various DOACs. If you have any patient, then you just estimate what is the thrombotic risk, what is the bleeding risk, and accordingly you can plan the interruption. Now, in some cases, if the patient has very high risk of thrombosis, you may give a low molecular weight heparin at low dose, that is 40 mg OD of enoxaparin or 5,000 units of dalteparin for the first 48 to 72 hours post the procedure till you achieve a hemostasis. So coming back to our case, this patient had DVT of 6 months ago. So thrombotic risk was moderate. Bleeding risk was high because of the polypectomy, which is planned. So the apixaban was stopped 2 days prior to the surgery. There was no bridging, and the apixaban was reduced on day +2. So because of the high bleeding risk, the total interruption was 4 days. Now, sometimes these patients may require urgent surgery. So you have a list of reversal agents. For dabigatran, we have the Praxbind, that is the idarucizumab. For the factor 10A inhibitors like apixaban, edoxaban and rivaroxaban, we have the andexanet alpha or the octaplex, that is the 4-PCC. And usually for warfarin reversal, again, PCC is preferred over FFP. Now coming to the antiplatelet management, agent management. So in most of the cases, aspirin can be continued. But I know even now, some surgeons, they prefer stopping the aspirin. So 7 days prior to the surgery, the aspirin can be stopped for the patient and you can resume the aspirin on the day of the surgery. If it's a minor procedure, then you don't need to stop aspirin. What about the P2Y12 inhibitors like ticagrelor and prasugrel and clopidogrel? So According to the agent and their half-life, the timing of interruption is there. For ticagrelor, it is a 3 to 5 day interruption. For clopidogrel, it is a 5-day interruption. And prasugrel, you have to stop 7 days prior to the procedure. So just to summarize for the DOACs, so in most of the cases, barring dabigatran, most of the cases you just need to stop the DOACs between day 1 and 4 days prior to the surgery or the procedure. And you can resume the DOACs 24 to 72 hours after the procedure has been done. In case of the antiplatelet agents, usually you can continue the aspirin, but if the clinician or the surgeon wishes, then you can stop it 7 days prior to the surgery. And for the P2Y12 inhibitors, it is depending on the specific medication given. Now, for the minor procedure, like I said, single antiplatelet agents like aspirin can be continued. If the patient is on dual antiplatelet, then you continue the aspirin and you can stop the P2Y12 inhibitor. This is just a table which is summarizing what I've just discussed in the past 20 to 25 minutes. Sometimes there are a number of patients who are on chronic parenteral heparin, whether LMWH or sometimes even fondaparinux, like, patients who are hit, although it's a very rare situation. But again, you can see here in this table that LMWH is interrupted usually 1 day prior to the surgery, as well as on the day of surgery, and then you can resume it from day +1. But fondaparinux, we need a 4-day interruption prior to the surgery. So total interruption days are 5 to 6. So just to summarize, whenever you are faced, you have a consultation regarding a patient who is planned for an elective surgery and is on an anticoagulant, you need to determine which anticoagulant the person is on. The patient is on a DOAC, then estimate the bleeding risk of the procedure. Whether if it is a minimal risk procedure like a dental procedure, then you just omit the anticoagulant, that is the DOAC, on the day of the surgery. So total interruption is 1 day. If it's a low to moderate bleeding risk surgery, then you omit the anticoagulant 1 day before the surgery, on the day of the surgery. So total interruption is 2 days. But if it's a high bleeding risk, like I discussed, so total of 4 days interruption, 2 days prior to the surgery, 1 day on the surgery, and 1 day after the surgery. What about the warfarin? Again, you estimate the bleeding risk of the procedure. If it is minimal, then you do not need to interrupt the warfarin. But in other cases, you determine what is the thromboembolic risk of the patient. So if it's the patient is falling in the low to moderate thromboembolic risk, you just need to interrupt the warfarin 5 days prior without any bridging. But if it's high, then you need to do the bridging as discussed. So my final slide. In patients who are undergoing surgery and are on anticoagulation, it is important to balance the thrombotic and the bleeding risk for optimal outcomes. Timing of the interruption and the bridging is as per the guidelines, very well laid down in most of the guidelines. The non-valvular AF patients, most of the cases you don't need to bridge unless if the CHADVAS score is coming more than 7. Most cases with mechanical valves, you may require a bridging. For patients who are having venous thromboembolism, only the high-risk patients need to be bridged, and you can consider post or prophylactic dose after major surgery. For DOACs, the bridging is not indicated, and you can restart the DOACs after 24 hours. And antiplatelets, mostly the aspirin can be continued, and the others like clopidogrel or ticagrelor, you need to withhold. Thank you so much for your kind attention, and I'll be happy to take any questions.
Thank you, Dr. Akanksha. Wonderful lecture. Wonderful to hear to you. And it was, I think, to the point, all BCHL guidelines, top to bottom. Thank you so much.
Thank you.
Fantastic. And I now request all of our discussants to please put the hand raise sign so that we can start with question session with Dr. Akanksha Garg. Yes, Dr. Gungar sir, please go ahead. You're muted, sir.
Good evening, Dr. Akanksha.
Yes, sir. Good evening, sir.
Presented very well. It was an excellent presentation.
Thank
You
you,
have
sir.
covered all the top. One thing I wanted practically, who decides this perioperative plan? This hematologist, whether cardiologist, physician, or surgeon, or anesthetist, who decides this? But do you plan some protocol?
So it's basically a teamwork. So if the patient is on, like patients who are having mechanical heart valves or they are having atrial fibrillation, so in those cases, you would definitely involve the cardiologist. And of course, the hematologist role comes in terms of, how you would bridge those patients or whether they need a bridging or not. So all that is important. And for patients, I think with venous thromboembolism, usually in our hospital, the practice is that they would consult us. If the patient is having, a history of ongoing DOAC or a warfarin, they usually consult us before they plan for the surgery for the bridging part. So anesthesia people do give the clearance, but we usually help them in planning out the perioperative bridging or the anticoagulation management. But of course, for the mechanical heart valve, type of valve, whether it was a cage ball or a tilting disc, I mean, all those details I'm not much aware of. But for those things, we need to take in, to rope in the cardiologist for their expert opinion.
But you have to make a protocol for the surgery.
Yeah.
If it's
So all
elective
the
surgery,
guidelines, they are very nicely given in the, the chest guidelines are there. You can easily follow them. They are very nicely given. Even this, for the DOACs, these, all the guidelines are clearly available. We don't need to mug up all these protocols. Just follow the guideline and plan accordingly. And for dabigatran, only dabigatran is the one where, we need to look after the creatinine clearance of the patient and then plan out how to interrupt and so on.
sometimes there's a scenario that patient is fully anticoagulated and patient needs emergency surgery.
Yeah.
So
Usually, sir, if urgent surgery is required, so in those patients, like I discussed, you would need to reverse the anticoagulation. So most of the cases, we are using the octaplex that is available in most of the centers. So that is preferred. We are usually giving that for the reversal if they need an urgent neurosurgery or anything like that, or if it's an RTA. So in those cases, we give. If you can still wait for a day's time, especially just to figure out that, how you would manage it, then you can wait for some time. Otherwise, if it's totally emergent, then you just give the octaplex and then you can manage the patient easily.
what are the
Aspirin
contents of
usually patients who are on antiplatelet agents, they sometimes say that you can, if they are planned for an urgent neurosurgery, then you can probably give them platelet transfusions also just to, for the aspirin effect to go. So that also can be done. Although that has not shown much, there's not much difference, but some of the clinicians are even following that for patients who are on antiplatelets.
what are the contents of octaplex, what you are saying?
So it basically 4 factors are there.
Okay,
So,
yes.
Yeah.
Four factor,
Pardon?
4 factor PCC.
Yes, that is the one.
Yeah. Okay.
Thank you, Dr. Kungar, sir. Dr. Satish Kumar, your question.
Thanks, Amit. Thanks, Dr. Akansha, for that excellent summary. So in extension of the last question, patients who are on antiplatelet drugs, aspirin, we know sometimes desperate situations, emergency surgeries, of course, if we can wait, that's better. In emergency situations, if they're on Brilinta, the P2Y12 inhibitor, what do you do in practice, Akansha? Patient needs emergency surgeries, can't wait because the effect takes at least 5 days for it to go.
Yeah.
So I think giving platelets also will not help in that situation. It's a very difficult situation
difficult.
we have faced. What do you do in practice? I know there are no guidelines, but in practice, what do you do?
So usually, I would not, I would usually, we keep platelets on standby, so if they require an urgent neurosurgery, we do that. And there is definitely, the hemostatic agents like Pranexa and all that we can give. But if we have to explain the risk to the patient's family, but I think platelets would be something. I don't think there would be much role of FFP in those cases. But
Yes.
platelets can be given, but that is, we don't have any, reversal agent for these, at least the PY12 inhibitors. So I think that's what we usually practice. But
And
there
there are
is
no guidelines.
there are no guidelines for that. Yes.
The second question is regarding restarting the DOACs after the surgery. Most of them you have written 1 day after surgery. many of them will be an epidural. So that becomes a challenge to restart
Yeah.
it 1 day after. I think we should just be careful if the
Yes.
patient is an epidural once
Yes.
it's removed after 12 hours, because we have seen a patient, an accident which was reported outside, patient developed epidural hematoma. I think we just need to be careful if the patient is an epidural.
So epidural comes in the high risk, the high bleeding risk. So in those cases, you would start it after 2 days.
Yeah. Just thought I'll comment on that. Yeah. Thank you. Thank you.
Thank you, Dr. Satish Kumar. Dr. Ali Mahmoode, your question, please.
I think me as a discussion. Ali Mahmoode from Ethiopia. Can you hear me?
Yeah, we can hear it now. Please go ahead. We can hear you.
Yes.
Yes.
My question is, my question is about heparin. I have not heard from you about unfractionated heparin, which has a very short duration of action as compared to low molecular weight heparin,
Yes.
especially in a patient who has high risk of thromboembolism post-surgery. Any study on the unfractionated heparin, because you can switch off easily.
Yes, but then in the post-operative time, you would need to do a very close monitoring in these patients. So that's why, I mean, most of the studies, like I discussed about the Periop 2 and the Bridge trial, they have mainly used the either the dalteparin has been used or the LMWH. So with the UFH, I'm not aware of any. I mean, the landmark trials have not used UFH. That's what I know. But yes, that is definitely an option if it is not possible. If the patient has, like patients who have deranged renal function, in those cases it is difficult to give the enoxaparin. You can give a UFH, keep them in the ICU, and at least do a close monitoring of the coagulation profiles.
Thank you so much. My second question is, I'm a pediatric oncologist.
Okay.
We see Wilms tumor patients with inferior vena cava thrombosis.
Yes.
What is your experience about the inferior vena cava filter if the patient has?
So yes, definitely. I mean, if in cases where you need in such patients, if you need any urgent surgical intervention, so in those patients, and because they have active cancer ongoing, so IVC filters definitely have been shown that in those rare cases you can place them for prevention of the thrombosis. So in those cases, instead of giving the parenteral, sometimes it may help in giving placing the IVC filters. So that has been especially in the patients who have high thrombotic risk, like newly diagnosed Wilms. So if he requires a surgical intervention, then you may use a IVC filter also in these patients, along with your anticoagulation. Of course, that you cannot skip, but an IVC filter can be used. But nowadays, I think it's a very rare indication. And especially in the pediatric, I am not very familiar with the IVC filter placement in the pediatric, but in the adult, definitely.
Thank you so much.
Yeah.
Thank you, Dr. Ali. Dr. Nimia Thanda, your question, please.
Thank you. Thank you, madam. I'm from Myanmar. I'd like to know your management plan and from your experience, and also from your experience, when a patient gets recent thromboembolic evidence, when he is going to do surgery.
Pardon? Can you just repeat the question? Sorry.
Yeah. When a patient gets recent thromboembolic events, when he is planning for surgery.
Yeah.
I'd like to know your management plan.
Usually they say that try to avoid it at least in the first month. The patient has developed a venous thromboembolism. Try to avoid the surgery in the first month of the VT. But if it is not possible, to postpone the surgery, then an IVC filter can be placed in these patients along with the anticoagulation. So that is one method, but we usually try to delay the surgery at least for 1 month post the acute thrombotic event. That's what the guideline says.
Thank you.
Thank you, Dr. Nimethanda. Dr. Ali, you had another question?
Sorry, I don't.
Sure. Okay. So there are some questions from the audience. Dr. Sutantra Kanan wants to know if a patient is on clopidogrel and aspirin and taken for urgent surgery with major bleeding risk, will you give platelets?
Yeah, so yes, I mean, if the patient is on dual antiplatelet and requiring urgent emergent surgery, then in those patients, it's better to give the platelets just to avoid any, excessive bleeding. So definitely.
Perfect. Another question is from Dr. Yong Kerwen. For post-plectomy patient for hemoglobinopathies, do you give thromboprophylaxis post-op? Number 1. And if yes, how long?
So, as per the thrombotic risk, for these patients post-splenectomy, usually it's not recommended, but you can just start them on the EcoSprint. So, if the patient is not taking the therapeutic anticoagulation, you don't need to start these patients. But yes, EcoSprint can be given in these cases. So usually EcoSpin should suffice. If you still feel that the risk of thrombosis is much higher, you may include either the mechanical ways of like the compression stockings, all that can be used. But giving anticoagulation, unless the patient has had an episode of thrombosis, I don't think there is any role. But most of the times for major non-orthopedic surgeries, aspirin can be given as a way of preventing, as a thromboprophylaxis in these patients.
How long can you give aspirin for such patients?
So post splenectomy, like this was a thalassemia major case, right? Post splenectomy.
We can take it
Better to continue it as a thromboprophylaxis.
Indefinitely.
Yeah. And anticoagulation only if the patient develops thrombosis.
Well, thank you. Another question is from Dr. Ganesha. If the warfarin has to be held for 5 days, how would you restart it?
So restarting would be because you've already held the warfarin. So for patients who are having a low to moderate risk of thrombosis, in those cases, you can just, you don't need to do a bridging. So because you're stopping it 5 days prior, and on the day of the surgery itself, you are restarting the warfarin. So there is no recommendation of giving again an LMWH for bridging. But if the patient is at a high risk of thrombosis, in those cases, the LMWH bridging is recommended. So only in patients with high risk of thrombosis, as per the guidelines and the table that I had shown.
Perfect. Thank you. Another question is from Dr. E. Montent. Is bridging with LMWH ever indicated for DOAC patients?
No, it's not. Only if there's only one place where if the risk of thrombosis is very high, you can give low dose LMWH, which is 40 mg OD or a dalteparin 5,000 units post-operatively. Otherwise, in majority of the cases, there's no bridging.
Just to add, basically, this is actually there is no bridging for DOACs.
Yeah.
Only for those patients who's going to start on deoxyriboxaban, we are just adding for 5 days LMWH.
Yes.
This is not considered as DOAC, but this is add-on to it for only for 5 days. And then after you're continuing the DOACs in whatever period of time you decided actually. So another question from Dr. E. Montant is, what is your approach to morning dose of DOAC administration for procedures scheduled late in the day?
So the guidelines say that it has to be at least, the interruption has to be at least 24 hours prior to the procedure.
Yes, so it is very clear because it all depends upon your creatinine clearance also. So 24 to 48, either or, left and right.
That is only for dabigatran, not for apixaban or rivaroxaban.
And if the creatinine clearance is elevated, then again the duration will be prolonged. Yeah. Well, so there are no more questions from the audience now. Well, thank you so much. So one question has come again. This question is from Dr. Raghvendra Rajesh Varkar. How is bleeding probability assessed and mitigated in ischemic stroke patients who need anticoagulation?
We have the Hasbled score is there for these patients, so that can be used. And for the, I mean, can you just repeat the question?
So the question is, how is bleeding probability assessed and mitigated in ischemic stroke patients who need anticoagulation?
So it is, we have the Hasbled score is there, so that will help in deciding whether the patient has a risk of bleeding or not. And again, you need to do a serial, if it's a pure ischemic stroke without any hemorrhage. So in those cases, you can start with the anticoagulation, and with the monitoring, you need to do a serial imaging also to just to see whether there is no hemorrhagic infarct happening.
Perfect. Another question from Dr. M. Velu. What is the cutoff of the platelet count to commence dual antiplatelets?
Dual antiplatelets, I think, so usually in my practice, I stop ecospin if the patient is on single antiplatelet, so I stop it at 25,000. And for dual, I think 50,000, 50 to 75,000 is the cutoff, if I'm not wrong.
So for dual, it is 50. For aspirin alone, 30.
Yeah.
This is according to BCG guidelines.
Okay.
Another question from Dr. Raghvendra Rajesh Varkar. In pulmonary embolism, there can be both embolism plus thrombosis plus hemorrhage also. So how will you manage if the patient has got embolism plus thrombosis plus hemorrhage?
So yeah, but the thing is that we've had a few cases where the patient, once we start them on anticoagulation and Clexane, they start having hemoptysis. So again, in these cases, I think a tag usually helps. So you take a decision based on your tag also. I usually, unless if the bleeding is not excessive, I usually and the platelets are normal, I would prefer continuing the anticoagulation rather than stopping it.
Perfect. Anybody's any other question? Well, so in that case, thank you, Dr. Akansha, for wonderful lecture. As always, it's always good to hear to you. You covered almost everything. All the guidelines was tip top. Thank you so much. And now I also request Dr. Ankit Rayani. Before that, let me share the screen once again. So we have a second guest speaker for the day. We have with us Dr. Ankit Rayani from Ahmedabad. Dr. Ankit Rayani is consultant hematologist and BMT physician at Cure Hematology Oncology Clinic at Ahmedabad. He completed his post-graduation in general medicine from prestigious Lokmanya Tilak Hospital, Sai in Mumbai. During his 3 years training of DNB hematology at Sahyadri Hospital, Pune, he acquired extensive experience in managing both benign as well as malignant hematological disorders. He has performed more than 400 autologous as well as allogeneic bone marrow transplant procedures till date for various hematological disorders. Currently, he is working at Cure Hematology Oncology Center, Ahmedabad, with attachments with various multi-specialty hospitals. His primary interests are in bone marrow transplants in both benign as well as malignant hematological disorders. He has published several papers and done oral as well as poster presentations at various national as well as international conferences. He is a reviewer for many reputed national and international journals in the field of hematology. Today he is with us and is going to lecture us on thrombotic thrombocytopenic purpura, new advances. Well, thank you so much. I stop over here. Over to you, Dr. Ankit Rayani.
Yeah, thank you, Dr. Amit, for that kind introduction. Thank you, Dr. Ambi Agarwal sir and MSG for providing this platform. Today my topic is thrombotic thrombocytopenic purpura. And as compared to other disorders causing thrombocytopenia, this is a rare entity. So many of times, even the physicians or referring doctor, they also don't know about this. So once you see a patient of thrombocytopenia and you diagnose that patient with TTP, and you call up the patient's physician, then he will tell you that I thought it was ITP. Then it is a tough job to make them understand it is TTP and what is TTP. So those of us who are new to the diagnosis, you can focus on the slide on the left side of the slide. So the RBCs having this damage, these RBCs are called cystocytes or damaged RBC, and these are usually found in disorders which have microangiopathic hemolytic anemia. And one more thing which is conspicuous is that we cannot see any platelets on this field of peripheral blood. So thrombocytopenia is one of the presenting finding in TTP. So we know the classical pentad of TTP. First is microangiopathic hemolytic anemia, or MAHA, as we like to call that. Second is fever. Third is thrombocytopenia. Fourth is renal dysfunction, which may not be very severe enough to require hemodialysis. And fifth is neurological manifestation, which we see usually in milder form initially. And if the patient is left alone without diagnosis, without treatment, then the patient may develop neurodeficit and ischemic or thrombotic events. So classical pentad, though described in literature, we usually see around 5 to 10% of the patient having all 5 symptoms or all 5 features, and majority of the time we diagnose the patient based on MAHA with thrombocytopenia, with or without fever or neurological deficit. So let us see the history of TTP. It all started with Moscovich first describing the condition in 1924. At that time, he did not know what was going on, but the patient had thrombocytopenia, bleeding, and thrombotic events. So a lot of sort of a paradox. In 1977, we found out that plasma can help in patients of TTP. And 1982, first time, a large VWF multiples were detected in TTP plasma, and that was the starting of understanding of pathophysiology behind TTP. Till that time, unfortunately, more than 90% patients of TTP succumbed to the disease. There was no effective treatment available. From 90s onwards, standard treatment was established, that was plasma exchange along with steroids. After that, the mortality drastically went down to less than 10%. And in 1996 and 98, we found out the enzyme or lack thereof, ADAMTS13, which is deficient in patients with TTP, and in immune TTP, ADAMTS antibodies were also identified. In 2003, role of rituximab in treatment of TTP in relapse or refractory setting was explored and approved. 2010 onwards, because of the patient surviving for more than 10 years, now we know long-term sequelae of TTP, comorbidities, cognitive dysfunction, vascular events, and so on. So we realized the burden of disease. And 2014, rituximab was approved as a frontline therapy in management of TTP. So 2019 came caplacizumab for use in acute immune TTP. And nowadays, the newer agents are ADAMTS13 recombinant factor, other novel therapy, immunomodulatory agents, and treatment without plaques. So that is the future goal, and the research is going on for that. So rather than reducing the mortality, now the focus is on reducing the burden of treatment and reducing the morbidity associated with that. So this is the pathophysiology of TTP. The main character is ADAMTS13, the blue man. His job is to break down the multimers of VWF or body movement factors. So sort of a clearance guy. So what if it is not there? So if there is no ADAMTS13, then these 1v1 factor multimers will keep on accumulating, and they will be clogging the vessels. So they are our platelets, they are very fond of this VWF multimers. So they also join the party, and they sort of form a microthrombi. So in large vessels, it may not be a issue, but in small vessels, small cerebral vessels, the blood flow is interrupted, the laminar flow is disturbed, and that results in intravascular damage to erythrocytes, and this damage can lead to appearance of cystocytes, pre-hemoglobin in plasma, as well as depleted heptaglobin, which is sort of a scavenger protein for free hemoglobin. So we saw the cystocytes, and this is a microthrombus formation on an actual pathology specimen. So there are two main types or ways of TTP. First is congenital TTP, which is also known as CTTP. Congenital TTP doesn't mean that it will present at the time of birth or early childhood. The presentation can vary significantly depending on the mutations. There are many mutations in the ADAMTS13 gene, and so phenotype will vary drastically. And second is acquired TTP, and acquired TTP is most likely because of immune mechanism, so we call it ITTP or immune mediated TTP. So clinical presentation, we had seen this slide, classical pentad. How the patient actually presents can vary from case to case basis. The crux is microangiopathic hemolytic anemia, that can be thrombotic microangiopathy, hemolysis is there, cystocytes are there, and purpuric spots because of thrombocytopenia. And organ involvement and damage, it can involve CNS, it can involve renal system, it can involve GI and liver, and it can also involve cardiac myocardium, and can result with can present with arrhythmia or cardiac dysfunction as well. What is the diagnostic parameters? So these all lab tests are required for diagnosis of TTP. Many of them are routinely available, many of them are not available. The most important lab parameter is ADAMTS13 activity. So for a diagnosis of TTP, ADAMTS13 enzyme activity should be reported less than 10% or less than 10 IU. For immune mediated TTP, it is essential to demonstrate a presence of ADAMTS13 inhibitor in the patient's serum, and for congenital TTP, that ADAMTS inhibitor should not be present. So that way we can straight away differentiate between congenital and immune mediated TTP. All the reports, they are corroborative, and ultimately helps us in the diagnosis. So differentials of MAHA. So TTP, that is our current topic. What else can cause microangiopathic hemolytic anemia? We are well versed with immune associated HUS. So anyway, if you have read Toxin book by Dr. Cook, so this first described the presence of HUS patient. And other thing is complement mutation HUS, or what we call atypical HUS, drug-induced TMA, transplant-associated TMA, malignant hypertension causing TMA, even DIC, APLA syndrome, and HELP syndrome. So these are all differentials of MAHA. They all will have different characteristic which will help us in differentiating between them and ultimately giving the right treatment to the patient. So earlier when ADAMTS activity was not available, we had a very good scoring system. Initially we used French score, very simple, platelet count less than 30,000, one score, serum creatinine less than 2.26 plus one score. If both both present, 94% probability of patient having TTP. If one present, 70%. If both absent, less than or 2%. So this was the simplified version, and with time, we found out other parameters which are also important. So plasmic score is the one which we use as of now. It incorporates hemolysis, +1 score for that, and hemolysis by indirect bilirubin more than 2, reticulocyte count high or undetectable haptoglobin. So that will constitute a score of hemolysis point. And there should not be any activity malignancy in previous year, so +1 score for that. No history of transplantation, solid organ or stem cell, +1 score for that. INR less than 1.5, so no conservative coagulopathy, so DIC, and +1 score for that. MCV should be less than 90, again +1 score for that. So if the patient had 6 or 7 score, total 7 score, and if the patient has 6 or 7 out of them, then there is a high probability of more than 60%. If patient has only 5 scores, if 2 of them are absent, then the score will drop down to less than 25%, and 4 or less, practically it is not present. So we can safely rule out TTP in that particular patient if the score is less than 4. So how do we monitor ADAMTS activity? So there are different methods which can detect ADAMTS activity very fast. Earlier turnaround time was very high, so that is why we had to use those scores, clinical scores or laboratory scores to differentiate between TTP and other causes of MAHA. Nowadays, most of the time ELISA-based methods are available. FRETS is one of the gold standard of this ADAMTS activity, may not be available in all the settings. So coming to 3 main assays which can be used for ADAMTS13 assay. So first is Hemosil AccuStar ADAMTS13 activity. So it is a CLIA method, and TAT for the analysis is 33 minutes, and it is a quantitative method, can differentiate, can detect level up to 0.2% to 150% for ADAMTS13 enzyme. Second is Technofluor ADAMTS13 activity. It uses FRET assay. Again, TAT is 25 minutes, quantitation between 1% to 125%. And third is semi-quantitative method, Technoscreen ADAMTS13 activity. TAT is 20 to 40 minutes, and because it is semi-quantitative, it can give results between 0%, 10%, 40%, or 80%. So these are the methods which helps us in reaching the diagnosis early. Depending on your locality, one or many of them may be accessible to you, and that will help you in reaching the diagnosis of TTP. So next is treatment. What we should do once we have a patient of diagnosed patient of TTP. So what are our goals? So we should prevent further microvascular thrombosis. We have to restore ADAMTS13 activity. We have to reduce autoantibody production so that ADAMTS activity is maintained. And we also have to take care of the comorbidity and give supportive treatment to the patient and avoid end organ damage, which can last for many years and can result in permanent morbidity. And lastly, we also have to prevent a relapse of the disease. Though this is a benign disease, it can present malignantly. So we have been using the term relapse for TTP. So the mainstay of treatment is plasma exchange. So this is a 1991 study which explored the use of plasma exchange with then standard of care, which was FFP transfusion. So it clearly showed us that giving plasma exchange to a patient will give us at least 20% survival probability for that particular patient as compared to only giving plasma infusion and not exchange. So plasma exchange has been first-line therapy since then. It helps in removing the autoantibodies against ADAMTS13. It also replenishes the ADAMTS13 enzyme from the donor plasma, and plaques it should be started as soon as we have a clinical suspicion of TTP and if the plasmic score is supporting. Daily plaques should be done with either cryopure plasma and or fresh frozen plasma. We should not use albumin because it doesn't contain ADAMTS13 enzyme, and thus we will not be able to replenish the ADAMTS13 when we use albumin as a replacement fluid for plasma exchange. And our goal should be to process at least 1 to 1.5 times of plasma volume for that particular patient, because it is an ineffective method. We are not removing the whole plasma at a time. There is a mixing, and that gives us a lower efficiency ratio for methods. And this would be 30% for membrane filtration using a dialysis machine, and up to 80% for apheresis machine by centrifugation method. But none of them is 100%, so we should at least plan to replace 1.5 times of the patient's total plasma volume in a single sitting. So lastly, we should continue it till the platelet count is normal range. That should be 1,50,000, and LDH is also normalized for more than 2 days, and then only we can think about stopping it. In congenital TTP, because there is no antibodies, so there is no role of plasma exchange. It can help us in replenishing ADAMTS activity, but there are many other more effective and less cumbersome methods available for that we will come to see in subsequent slides. So not required in congenital TTP. So this makes it more important to determine whether that particular patient has immune mediated TTP or congenital TTP as soon as possible. So what is CPP? CPP stands for cryopure plasma. So it is the fluid or plasma remaining after removal of cryoprecipitate. So it contains less von Willebrand factor. So it should be a ideal fluid replacement, and it decreases the von Willebrand multimer burden as compared to FFP. So this has been studied in head-to-head comparison between with FFP in this 2023 article, and it says that if you see the forest plots in all the patients receiving CPP as compared to FFP, the risk of events it was less and in favor of CPP. Again, overall mortality in RCT was also in favor of CPP, and relapse risk was almost same, because ultimately relapse depends on antibody formation that can happen later on. So in primary management, cryopure plasma is better than FFP for plaques. The second pillar of treatment is anti-CD20 antibody, rituximab. It targets B cells producing anti-ADAMTS13 antibodies. It use in TTP can be either frontline in relapse refractory setting and prophylactic or preemptive use in a patient who had TTP earlier, but not right now the patient is asymptomatic. So this is a phase 2 study, first published in 2011, exploring the role of rituximab in acute, acquired or immune mediated TTP. So if you see the comparison between two curves, the trial patients receiving rituximab had a higher percentage of remission, remaining in remission, more than 80% in fact, at the end of 50 months as compared to a historical cohort where there is 50% chance of relapse after maybe 40 to 50 months of initial treatment. So upfront use of rituximab helped in sustaining the remission for a longer period in a larger proportion of patients. So role of rituximab again can be in initial treatment. That same paper by Dr. Scully that recommended use of rituximab in upfront setting. 2012 paper by Prasad again explored the use of rituximab in a refractory episode of TTP, where it was recommended with a category 1C evidence and grade. And in contrast, when the patient is in remission but has a severe ADAMTS13 deficiency on ADAMTS13 assay, in that case, this 2014 paper recommended against use of prophylactic rituximab in patients who are symptom-free with low ADAMTS13 activity. So that was in 2014. So right now we have a ISTH update, 2025 update of the TTP guideline. What are its recommendations for patients with immune-mediated TTP experiencing first acute event? It strongly suggests addition of rituximab to corticosteroid and TPE versus corticosteroid and TPE alone. Second thing is patients with immune TTP who are in remission but still have low plasma ADAMTS13 activity without any clinical symptoms or signs. Use of rituximab is recommended by the panel in contrast to the earlier paper over non-use of rituximab for prophylaxis. So that prophylaxis can be customized. There is no guideline for that, how to do it, but it has been recommended with a very low certainty of evidence. So this is the role of rituximab. Next is adjunctive or supportive treatment, corticosteroid. We use it with IV methylprednisolone or oral prednisolone. It reduces autoantibody production and can be given with plaques. And other thing rather controversial is use of anticoagulation or anticoagulation. To be started once the platelet count is more than 50,000, low dose aspirin or low dose LMWH can be given. And we should be very careful and not add it when patient is also receiving caplacizumab because it increases the risk of bleeding events. So what are the updates of 2025 guideline ISTH? So patients having ITTP with a first event, addition of corticosteroid strongly recommended. On the other hand, there is no mention of aspirin. Instead, LMWH can be considered for patients with immune TTP with platelet count more than 50,000, and for those patients who have an increased risk of venous thrombosis because of vascular insufficiency, because of lack of mobility and so on. So LMWH use for patients who have partially recovered and platelets are more than 50,000, we can consider the use. So the newest agent, which is caplacizumab, it is an anti-VWF nanobody. So it is a bivalent variable domain only immunoglobulin fragment. It's not a complete antibody, it's a nanobody or antibody fragment. What it does is it covers A1 domain of VWF and thus preventing the interaction between VWF multimer and platelets. So it avoids or prevents the formation of thrombosis. So this connection, it is interrupted by the addition of this caplacizumab, and microthrombi formation is reduced. It because of lack of consumption of platelet, it accelerates the platelet count recovery. It also reduces relapse, and it has been indicated in frontline for acquired or immune TTP with in addition to plaques and immunosuppression, steroid and rituximab. So the dosing, first dose administered upon initiation of plasma exchange therapy. So 11 mg bolus at least 15 minutes before plasma exchange, followed by another dose of 11 mg subcut after completion of plasma exchange on day 1. So first dose is IV, then subsequent all subcut doses. And subsequent days 11 mg subcut once a day after plasma exchange. So once the patient's plasma exchanges are over, we can continue 11 mg subcut once a day for 30 days more after last plasma exchange. So the duration would be number of plasma exchange days plus 30 days, complete duration. And if the signs of persistent underlying disease is present, we can extend it up to more than maximum 28 days. So up to 28 days more after that. And we have to discontinue the medicine if there are 2 or more occurrence of acute TTP while on caplacizumab. If it is not working, better to stop it. So this is the first trial, again by Dr. Maris Kali and group, Titan study, published in 2016 NEGM, which explored the use of caplacizumab in comparison to placebo with PE. So the red cows are for placebo and the blue cows are graphs are for caplacizumab, and this is proportion of patients without confirmed platelet normalization. So after adding caplacizumab, in 3 to 5 days, almost 50% patient had a platelet recovery as compared to placebo group where the recovery was more than 5 days. And ultimately it led to clear separation of 2 curves with patients receiving caplacizumab doing quite well as compared to patient without. So this was again further explored in Hercules trial, again with Dr. Maris Kalian group, and published in January 2019, which again confirmed that use of caplacizumab had a better platelet or earlier platelet recovery rate as compared to placebo group. A long-term follow-up. So here you can clearly see the difference. The rate ratio for normalization of platelet count, caplacizumab versus placebo, was clearly in favor of caplacizumab with a p-value of 0.01 and a hazard ratio of 1.55. Secondary outcome, again clearly in favor of caplacizumab, composite of TTP related death, recurrence, or major thromboembolic event. So these are the major problems that patients of TTP will or may have. So clear cut benefit with a p-value of less than 0.001 in favor of patients receiving caplacizumab. So what about triple therapy? In addition to plaques and rituximab and caplacizumab. So this is the triple therapy, and this has been published in 2021 Blood. So patients treated with triplet regimen were 6.2 times less likely to have refractory immune TTP or TTP related deaths as compared to patients from historical cohort. So this again shows the same hazard of recovery or probability of recovery on patient receiving the triplet therapy on red cow much better as compared to patients receiving only doublet therapy, so blue cow. So clear benefit of triplet therapy. So this can be one of the future therapy direction. ADAMTS activity, again red bars showing use of triplet therapy, 50% crossed within 28 days as compared to patients receiving doublet it took around 42 days for them to cross 50% mark. And ultimately, the residual activity was even higher, almost 80 to 90% median activity as compared to patients having doublet therapy. So what about the long-term use of caplacizumab, and what are the pitfalls against the use of caplacizumab, or red flags against the use of caplacizumab? So this is a real-world study published in Thrombosis and Journal of Thrombosis and Hemostasis in 2023. So it sort of a review article, and it had more than 15 studies which it reviewed, and this was the conclusion of this review article. Without caplacizumab, patients with immune-mediated TTP have a 15 to 55% risk of exacerbation or any complications. Caplacizumab has been shown to significantly reduce refractoriness and exacerbation in RCTs and RWE. It shortens the time to platelet normalization, thus reducing the time required for acute ITTP to accumulate ischemic organ damage. Again, a real-world experience of caplacizumab. It can this study explores use of caplacizumab, rituximab, and glucocorticoids without plaques. And in some patients where plaques is not possible, so this can be one of the way out for treating those patients effectively. So we can see the activity is rising more than 20% within 25 days of commencement of treatment, and platelet count also remaining stable more than 1 lakh. So plaques is not compulsory in all patients. We can avoid plaques if the patient is sick, frail, or has contraindication to plaques, including reaction, trolleys to plasma being given. So this is one of the other treatment modality. So what about what ISTH 2025 update says about it? So patients with ITTP experiencing an acute event, use of caplacizumab is moderately recommended over not using caplacizumab. So if possible, we should use it. So next is refractory TTP. So those patients who are not responding to initial therapy, the patients who are not doing well, requiring plaques for more than 15-20 days, so dreaded cases which take a lot of toll on patients, their relatives, and even physicians. So we should first revisit the diagnosis. Are we really treating TTP? There can be a thrombotic microangiopathy, which can be due to underlying solid tumors, adenocarcinoma, more likely. We may be treating a patient of atypical HUS, wrongly diagnosed with TTP. It can be a drug-induced TTP where the offending drug is also inadvertently still continued. And the second is we have to review the adequacy of treatment. So mainly for plaques, we should at least process 1 to 1.5 times of plasma volumes in each sitting, and we ensure the use of FFP or CPP. Albumin should not be used as replacement because it doesn't contain ADAMTS13. So there is no replenishment of the ADAMTS13 activity after plaques if we use albumin. And third is centrifugation method. It's much more efficient over filtration method, 80% versus 30%. So if the filtration method is not working, dialysis machine is not giving the result, then maybe you can switch to apheresis. And lastly, rituximab, if given in lower dose or before plaques, then it will not work. And there can be other factors which can complicate the clinical course, including infection. We had a patient who had a CMV reactivation, which again had a feature of thrombocytopenia or cytopenia. So that patient did not have a relapse of TTP, but he had a CME reactivation causing thrombocytopenia, which was found way later on. So in truly refractory DTP, vincristine 2 mg slow IV administration has been used. Single dose as per the guidelines of ISTH, but we have been using more than 1 doses without significant bone marrow separation. Second is cyclophosphamide, again 500 mg IV over 2 hours, single dose, not more than 1 dose because it can lead to bone marrow separation as per the ISTH guideline. Cyclosporine 2 to 3 mg per kg per day intravenous, followed by equivalent dose of oral cyclosporine, 2 divided doses per day. And duration of therapy as per the patient's progress and morbidity, it can be prolonged up to several months, followed by tapering. So these are based on anecdotal reports and not a clear recommendation of the ISTH panel. So what other medicine can be useful in some cases? Azathioprine has been used in TTP patient, at least for those patients who has a relapse as a sort of maintenance period, maintenance therapy following second remission, and it has worked in some patient, so it can be explored. Second is eculizumab, because there is evidence of complement activation in TTP also, so it may be used in some patient, but no great data, so no recommendation for routine use. We know what is not useful, IVIG. So in these patients, TTP, IVIG is not a option of not giving plaques. So like in Guillain-Barré syndrome, IVIG and plaques both are option. Here we cannot give, we cannot replace plaques by IVIG. It doesn't work. And splenectomy earlier done to increase the platelet count actually had a even worse impact. So clearly not indicated. What are the new agents which are sort of being worked upon? I'm just going to mention 2 of them. So this is TAGX0004, which can also inhibit the von Willebrand factor activity by platelet aggregation assay. So it's supposed to be possessing better pharmacological properties as compared to Gaplacizumab, and may show promise for a acute TTP, acute immune-mediated TTP treatment. So one more is recombinant ADAMTS13, which is now available for clinical use, approved, usually used in congenital TTP. So this was a trial reported in NEGM 2024. So patients receiving recombinant ADAMTS13 had a better recovery of thrombocytopenia and LDH level as compared to patients receiving the standard of care, which may be plasma exchange or plasma infusion for congenital TTP. So this is only for patients having congenital TTP, not for immune-mediated TTP. So again, this shows the efficacy of recombinant ADAMTS13 as compared to fresh frozen plasma, plasma treated with solvent detergent process, and plasma derived factor VIII von Willebrand factor concentrates. So till 2020, plasma derived factor VIII VWF concentrates were one of the recommendation for use in congenital TTP, but nowadays they were removed it based on this study where it shows very less efficacy, if any. Second is plasma, fresh frozen plasma, and the best one is recombinant ADAMTS13 activity for restoring the ADAMTS13 activity. So recombinant ADAMTS13 enzyme is the best available treatment for congenital TTP as of now. So during prophylaxis with recombinant ADAMTS13 in patient with congenital TTP, the activity reached approximately 100% of normal level. Adverse events were mild or moderate in severity, and TTP events were rare. So clearly indicated. What about immune thrombotic thrombocytopenic purpura? ADAMTS13 recombinant agent may not be beneficial because it will be actively taken out by the antibodies which are present in immune from TTP patient, but it can form an antigen antibody complex which can saturate the autoantibody and may overcome the autoimmunity. So it can found a way in treatment of immune thrombotic thrombocytopenic purpura in future. As of now, no, not recommended. So one more methodology is recombinating and modifying ADAMTS13 protein to take out the epitopes which are targets of antibodies. So this has been a focus of research, and if they are able to find out ADAMTS13 enzyme which cannot be targeted by the autoantibody and which is effective in cleaving the 1 factor multimer, in that case it would be the ultimate agent for treating immune thrombotic thrombocytopenic purpura. So that is our current target, and the progress is going on for that. Coming to congenital TTP, we'll just I'll shortly mention it. It's also known as Upshaw-Sulman syndrome, autosomal recessive condition. More than 200 mutations are identified in the ADAMTS13 gene located on chromosome 9. And depending on the mutation, there is wide variance of clinical phenotype. So residual ADAMTS13 activity of less than 3%. It was correlated with early onset of disease, need of prophylactic plasma infusion or ADAMTS13 infusion, and annual event rate of more than 1. If the patient has more than 3% activity but less than 10%, those patients can present late or may not require any treatment lifelong. So it can be a hidden menace and present during certain situation only. So one of the situation is pregnancy. So there is a 2012 article showing unexpected frequency of Upshaw-Sulman syndrome in pregnancy onset thrombotic thrombocytopenic purpura. So this study evaluated pregnant female having a first episode of TTP, and total 590 patients were included. 400 were women, and out of them 280 had less than 45 years. 48 women had a one episode of postpartum or pregnancy associated TTP. So those 48 patients, out of them 42 had a first episode of postpartum TTP. So these 42 patients were again evaluated for ADAMTS13 inhibitor. So if the anti-ADAMTS13 IgG or inhibitor both were negative, in those patients, ultimately after filtering more, they found out that out of these 19 patients, 10 patients had congenital TTP. So 42 pregnant female first episode of TTP, almost 10 patients were found out to be not immune mediated TTP but congenital TTP. So almost 30%. So what is the recommendation for ISTH guideline 2025 update? For patients with congenital TTP who are in remission, panel recommends the use of recombinant ADAMTS13 or plasma infusion to prevent acute events. So prophylactic use of ADAMTS13 recombinant factor. If it is not available, then plasma infusion as a prophylaxis is also recommended with a low level of certainty as compared to wait and watch. So a couple of slides. What is the algorithm for newly diagnosed TTP patient? the patient has come with thrombotic microangiopathic anemia, then let us see what is the ADAM-TS13 activity. If it is more than 10%, then we evaluate for other TMA, including atypical HUS, transplant-associated TMA, and so on. If the activity is less than 10%, then we confirm the diagnosis of TTP. Then we have to check for ADAM-TS13 antibody in the patient's serum. Suppose it is positive, then the diagnosis of immune-mediated TTP is confirmed. If ADAM-TS13 activity is negative, and if it is more than 10% in remission, and then we have to again check for ADAM-TS13 IgG antibody at the time of relapse. If it is positive, then it still can be a immune-mediated TTP, because ADAM-TS13 inhibitor can be taken out by residual ADAM-TS13 or treatment and can result in false negative. So we have to check multiple times before labeling it that it is not immune-mediated TTP. So in those patients, it can be falsely negative in presentation or due to treatment. If it is always negative, then it is TTP of unknown mechanism. And if the level, if it is remaining less than 10%, ADAM-TS13 activity is always less than 10% without treatment, then we have to check for ADAM-TS gene mutation. If positive, congenital TTP is confirmed. If negative, then we have to search for any other etiology. What are the take-home messages? TTP is a medical emergency. Timely diagnosis, prompt and adequate treatment decreases the morbidity and mortality. ADAM-TS13 activity and inhibitor assay, both are essential for better perfect treatment of the patient. Congenital TTP can manifest for the first time in adulthood. We cannot rule it out for a patient who is presenting first time in adulthood, and can be easily mistaken for immune-mediated TTP. Patient will receive plaques unnecessarily without any clinical benefit, and ultimately will have a level of refractory TTP, because he or she will relapse once the plaques are over, because ADAM-TS13 activity is not maintained. So very crucial to differentiate between them. So for ITTP, plaques, rituximab steroid mainstay, caplacizumab effective agent in reducing the response time and morbidity. In Western countries, including Spain and US, there have been studies to prove the cost effectiveness of caplacizumab. But in countries where the resources are less, caplacizumab may not be an ideal candidate. And with timely treatment, mortality in immune-mediated TTP has been reduced for from near 100% to less than 6%. So it is our job to treat the patient. These are the sources for my presentation. I thank you so much for your patient listening. Just stop my screen.
Thank you, Dr. Ankit. Wonderful lecture. From A to Z, you have covered everything all of TTP. 2025 ISTH update. That's fantastic. Thank you so much. And now I request all our discussants to please put the hand raise sign so that we can start the question session with Dr. Ankit Rayani. Let's first go with Dr. Ali Mahmoodi. Your question, please.
Thank you so much. It was excellent presentation. My question is, a pregnant mother with immune-mediated TTP, what is the risk to the newborn?
So that depends on when the TTP has occurred. So at what time of the pregnancy the TTP occurs? Usually it is in third trimester or after delivery. Suppose it has occurred after delivery, there is no risk, obviously. But if the patient is in the third trimester and the TTP occurs, then the risk will increase, because the platelet count will decrease, risk of antepartum hemorrhage, risk of thrombotic events, including placental thrombosis, will increase. So in that case, the patient will have a miscarriage. So in fact, one of our patient had a previous history of miscarriage and was diagnosed in second pregnancy with TTP. So that has happened 4 years between two pregnancy. So in 4 years, patient was all right, but again patient had a second gravida, second pregnancy, and again the patient had fall in platelet count. At that time, she was diagnosed with congenital TTP.
Thank you so much. So can a newborn get also TTP by
No.
chance?
No.
They are like,
So because it can, it's not a contagious disease. Second thing, antibodies, though it can travel or cross the placenta, but the amount of antibody is not very high, like in ITP. So what your question is, whether the newborn will have thrombocytopenia at the time of birth? Not likely. And no bleeding risk for CNS bleed risk for newborn. But if we consider it as a hereditary phenomena, suppose the patient herself has congenital TTP, then also it's a autosomal recessive disease. So less chance of vertical transmission to the newborn.
thank you so much. My second question is why IVIG is not effective unlike other autoimmune condition in TTP?
IVIG sort of acts as a smoke screen. So maybe in patients with ITP, patients having anti-GBM antibody, like in Guillain-Barré syndrome, maybe IVIG, they are able to saturate and prevent the contact of antibody to antigen site and give outcome. But in somehow in TTP, the antibodies maybe they are not able to the IVIG, they are not able to separate the anti-ADAMTS antibody from ADAMTS enzyme. So that is how they fail, and ultimately unless we take care of the production of ADAMTS 13 antibody, IVIG will not have a long duration of response.
Thank you so much.
Thank you, Dr. Ali. Dr. Jaswantini, your question, please.
Hello, sir. Good evening. It was a very excellent presentation. Sir, my doubt would be, like you told, in pregnancy, actually, first time, patient can be diagnosed with congenital TTPs. So in such cases, how to monitor them? So after pregnancy, in resource constrained settings where we can't give them recombinant Adam TS13, you ask them advice to give for plasma, right, sir? So how frequently should they receive plasma? Like how to monitor them?
Yeah, so like I showed in one of the slide, if baseline ADAMTS 13 activity is more than 10%, let it be less than 10%, but more than 3%. So 3% to 10%. In those patients, the presentation can be episodic, just like thalassemia intermedia. They may require during certain situations like pregnancy, for example, right? And they will not require a prophylactic ADAMTS 13 replacement or plasma replacement for where their resources are not limited. Their prophylactic use of ADAMTS 13, recombinant ADAMTS 13 is recommended, but in our country or equivalent countries, we can be more judicious and use plasma or ADAMTS 13 enzyme if the platelet counts are dropping. So rather than monitoring the ADAMTS 13 activity, which itself is a very costly method test, we can just monitor the platelet count.
Okay.
So we have two patients of congenital TTP presenting in postpartum period. So
Okay.
both of them are doing well and are off plasma infusion, not
Okay.
exchange, infusion also, and they are maintaining the platelet count. So only advice is to be very vigilant during next pregnancy, if any, and during any situation where the platelet count can drop further.
Okay. Apart from pregnancy, any other specific triggers we should watch for, sir?
Not known, but it can be drug induced, something which can trigger the precipitate the ADAMTS13 activity.
Thank you, sir.
Thank you, Dr. Jaswantini. Dr. James Khungar, sir, your question, please.
Good evening, Dr. It was very excellent talk. You have covered all the topic. You have complete all the topic. I just want, it will be helpful to the audience practically what are the key clinical features when you suspect and when you start the plasma exchange, and whether you give rituximab upfront, steroid upfront, or how you monitor whether you transfuse platelets also, or and if you give whether by central, if you insert central venous line, or just practically.
Right. Yeah, so
will be helpful to all the.
Sure, sir. So first is coming to the diagnosis. So suppose a patient with thrombocytopenia is referred with bleeding symptoms.
Wait for all five.
Yes. So it is very clear that all the pentad will come later on in the treatment or case history. If we wait, the patient is not diagnosed in time, then the patient will come with CNS event and all. But initially, our diagnosis should be based on MAHA, that is microangiopathic hemolytic anemia, which can be a sudden drop in hemoglobin with cola colored urine, high colored urine, jaundice, as well as thrombocytopenia and thrombocytopenic purpura. So patient with this symptom, with or without fever, with or without headache, and there can be even body ache, even muscle pain is also reported because of low perfusion. So these are the red flags where we don't think about ITP and we think about TTP. So hemolysis, active hemolysis, along with thrombocytopenia, and peripheral blood examination is I think easily accessible, readily accessible test which can give us the diagnosis. If it is not available,
2%.
Yeah, so if it is not available or it's not reliable, then what we can do is we can do a bedside test to check for free hemoglobin. We can just give the patient's blood in a serum, actually, in a serum tube, and let it clot. If the supernatant is having red color, then it has a free hemoglobin. If again urine, if a patient has hemoglobin urea, which can happen because of intravascular hemolysis, then it will not precipitate. If hematuria is there, it will precipitate, and the supernatant will be clear. So these are the tests which can guide us. But ultimately, ADAMTS13 activity, if possible, we should do it, and we should also check for inhibitor. So I think as of now, inhibitor assay, which is a Bethesda assay. So by that we can get the actual inhibitor level, just like we do it in hemophilia for factor 8 inhibitor, factor 9 inhibitor. So we can do a Bethesda assay for ADAMTS13 inhibitor, but it will be very costly. But each step we have to do a ADAMTS13 activity. So it will be around 6 to 7 steps. So what we can do is we can do just a mixing study. We can, once we establish that the factor ADAMTS13 active is less than 10%, we mix patient's plasma in 1:1 proportion to test plasma, and still if the activity is less, that confirms the diagnosis of immune mediated TTP as compared to congenital TTP, where there is no inhibitor and the activity will increase maybe up to 50%, right? So that is how we differentiate between congenital TTP and immune mediated TTP. If congenital TTP, we don't need central venous access because the treatment is via plasma transfusion and not exchange. But in immune mediated TTP, we need a HD catheter, so that either we do it on a apheresis machine or we do it on a dialysis machine. Venous access will be required. So initial placement of catheter should be USG guided by a experienced internist, so that to avoid hematoma formation, and we avoid femoral lines, because the risk of thrombosis is much higher in femoral lines. So we usually do it in IJV placement of HD catheter. Tendency is to do in femoral veins to avoid bleeding symptoms, but we should know that TTP is actually a thrombotic event, thrombotic phenomena. So if the placement is done in IJV, there is less chance of subsequent thrombosis or DVT as compared to femoral catheter, because at least we are thinking about 10 to 15 days of line, because that much time will be required for platelet to normalize and plasma exchange to continue. So better to put it in a good site rather than doing it in a safe way. So that is one thing. And once we start plaques, we usually do it 2 times in first day, 2 times, morning and evening, at least 1 to 1.5 times plasma exchange, and we use CPP, cryopore plasma, and we make sure that donors are not multiparous women. So there is a less chance of TRALI. Less chance is not 0%, but less chance as compared to otherwise. And because so much plasma is required, sometimes we don't get the exact blood group. So we should know that in plasma, the blood group acts in reverse way. So O positive and is a universal acceptor, and AB negative is universal donor. So that is the practical consideration, and we try to make sure that all the plasma removed is equally replaced by plasma only, FFP or CPP. And we can, in apheresis machine, we can actually see the plasma color. That will give us the sort of indirect way of getting the activity or judging the activity of the TTP as of now. So in first 2-3 settings, it will be dark brown color, and once the hemolysis is down, then the subsequent plasma exchange, they will show normalization of plasma color removed from the patient's blood. So and we usually daily do, because we have access to hematopathologist, so we daily check for cystocytes, platelet counts, manual platelet counts, and we also monitor LDH. So ultimately, once the platelets are more than 50,000, we start antiplatelets. We have not been using LMWH as of now, and rituximab and steroids. Steroid we use methylpred. So we start from day 1 onwards, and rituximab we start after first 2 days of apheresis if the patient is okay.
Upfront you give rituximab, you don't wait for 5-7 days. Suppose there is no response, you are less response, then only you add rituximab.
Sir, yeah, rituximab, the role is not for the current event. Rituximab, the role is for prevention of subsequent relapse. So all patients where there is a strong autoimmune history or ANA is positive, in those patients we usually give upfront rituximab in first event itself.
How much
so
dose?
that to relapse.
375.
Sorry,
375 weekly.
Yes, sir. Yes, sir.
Into how many weeks?
So 4 weeks.
4 weeks.
Usually like ITP, just like ITP, and we give it after plaques, whatever days it is falling on.
Okay.
And platelet transfusion?
Transfusion, unless there is active bleeding, CNS event, it's like adding fuel to fire. So unless absolutely indicated, we try to avoid.
What is the cutoff platelet count?
No cutoff. No transfusion prophylactic, only when there is active bleeding. Otherwise, no cutoff, sir.
Thank you.
Yes, sir. Thank you.
Okay, Dr. Kungar, sir. Dr. Gopinathan, your question, please.
Thank you, sir. Thank you for that excellent view. I mean, felt like reading all over for the TG exam once more time. So my question starts with the same thing. The rituximab dose dosing, are we doing 375 or now I read the recent paper stating that even 100 milligram weekly once for acquired TTP is as efficacious as 375 milligram per meter square. So I just want to understand regarding the dosing strategy for rituximab.
You're muted, Dr. Ankit.
Yeah, sorry. So if we give a lower dose, it will have, this is not for current episode, first of all. So this is for preventing the future relapses. So in that case, giving a lower dose, like in ITP, it can be counterproductive. This episode will be taken care by glucocorticoids, removing the anti-ADAMTS13 activity by plaques. So rather than giving a lower dose, I would prefer to give full dose of rituximab. I have not seen, frankly, results of lower dose of rituximab over a long period for same patient longitudinal study. Having said that, one advantage of giving lower dose would be to sort of minimize the infective episodes. Like I told, in one of my patients, we had a CMV reactivation. That patient had CMV encephalitis, and that was COVID period. Ultimately, she had a COVID infection, and we lost her, though she was in remission. So that happened at that time. So after that, in some patient where we feel that the patient is fragile, we may not give rituximab upfront in first line treatment, elderly patient, but in young patient, fit patient, we give full dose.
I think the explanation that they gave in that paper was the autoreactive clone that is triggering this event is very minimal, and that is sufficient to be ablatable by this even 100 milligram. I mean, they did compare the old cohort and the new cohort, and they said, so that's why I just had a doubt. So still we follow the same 375 mg per meter square, but in a couple of patients where like we were telling a little bit frail and weaker, I used 100 also, and I can say those patients are also in remission. So that's why I just had this thought. And once after attaining remission, how do you just follow them up? Do you just put them on some follow-up immunosuppressants like you do MMF, or what is your choice of immunosuppressant for?
So we have been using azathioprine for patients, but up to 2 years. If there is no relapse up in 2 years, we take it out. We take it out. So many of the patient, those patients who are going to relapse, they will relapse within 6 months or 9 months, within 1 year. So long term, we have follow-up of more than 20 patients. Those patients who had a relapse, those are on MMF or whatever has clicked for that particular patient. But routine, we use azathioprine for 2 years and ecosprin, aspirin for 2 years.
And regarding this congenital TTP, I think I've hardly seen 3-4 patients of congenital TTP because of maybe the rarity of the situation. So as in reserve continuous settings, when we do this plasma replacement, so is there a theoretical possibility that we end up having inhibitors in, like as we have in deletional mutations of hemophilia, do we end up having inhibitors to the plasma products of one?
Theoretically, yeah, it can be possible, but I think the question is that is there any possibility of inhibitors in congenital TTP patient? Theoretically, yes, but practically less likely because it is not 0%. Seen in severe hemophilia, it is not less than 1%. Most of the time, the patients, they have around 2-3% of activity. So those patients, they are less likely to deliver get an inhibitor because they have the immune system has seen the ADAMTS early in life. So those say B cell or plasma cells, those who are autoreactive would be taken care by thymus.
Thank you. Thanks, sir.
Thank you, Dr. Gopinathan. From the same note, what about bortezomib and daratumumab?
So daratumumab has been explored in congenital, acquired TTP, and there is some data, but not likely in all patients because most of the time the anti-ADAMTS13 antibody source is not plasma cells. it is lymphocytes, B lymphocytes. So in those patients where rituximab is not working and the patient has a refractory disease or multiple relapses, in them we can think about using bortezomib or daratumumab, just like ITP.
Thank you. Another question is from Dr. Hitha B. How do you go with the prophylaxis in cases of congenital TTP, Upshaw-Sulman disease, in a patient who is 4 years old male child, only one episode of hematuria, but no thrombosis at all? So how do you go with prophylaxis and what drug to be used?
So a patient presenting young in 4 years of life.
4 years.
So in those patients, it is likely to be severe disease. So you should at least get a ADAMTS 13 baseline level done when the patient is asymptomatic and give a 3 to 4 weeks of window period from last transfusion, last FFP transfusion, and do a baseline level. If it is more than say 3%, suppose it is 5% or 7% of residual activity, then that patient will be less likely to have a recurrence or more than one per year of event rate. So in that case, prophylaxis is not recommended. But those patients who are having multiple episodes or likely to have multiple episodes, in those patients, prophylaxis is recommended. So baseline level of less than 3% of ADAMTS activity, multiple events, more than one episode in 1 year. In those, as of now, we have only one access, that is plasma. So in those patients, plasma infusion 3 to 4 weeks, every 3 to 4 weeks, should be taken as a prophylaxis. So both of them, it is efficient. We don't have to do it more frequent than that.
How long do you call up the patients of congenital TTP?
Till the time they fed up with us. And
every how many months?
How many months? So usually they don't come every month. So once that for our patient at least, once that routine is established, most of the time they take plasma at local place. They come every 3 to 6 monthly for just routine follow-up. But plasma infusion, most of the time they prefer to take at local place.
So you will monitor after like for 3 or 4 months, because we need to check for LDH and the platelet count.
Yeah. So
Platelet
initially
dropping,
yeah.
the
So
LDH is going high. So
right.
are we supposed to give plasma or you're not supposed to give plasma?
Suppose platelets counts are dropping or LDH is going up, hemoglobin is dropping, patient has high colored urine. These are active, it's an active event. In that case, we have to give. If the patient is not maintaining without plasma infusion, then that patient will require. So depending on the patient's progress or behavior over the time, we will come to know for that particular patient how much plasma or how many months of plasma infusion is required. So those patients who have episodic bleeding and are doing well without plasma infusion, they are likely to be plasma free for a long period.
So follow up every 3 to 6 months is fine.
Yes. Yeah. So unless there is any problem, any infection and any surgery is there and patient has thrombocytopenia, then they will come early and we will give plasma so that the platelet count increases more than 1,50,000. Otherwise, even a platelet count of 1 lakh, if the patient has no hemolysis or no other signs of TTP, then it is fine.
Fair enough. Another last question is from Dr. Sui Louis 10. In patients who is SLE with TTP, is the approach similar or you do anything else?
No, it's almost similar. So SLE, the culprit is antibodies. It can be more than one antibody. Some may be targeting kidney, some may be targeting ADAPTS certain activity, some may be targeting platelet factors. So ultimately, rituximab, yes, plasma exchange, yes, they will work in both. And those patients who are refractory, those patients where nephritis is there. So in those patients, I think cyclophosphamide is a good choice. So that will all help in both.
Fantastic. And another last question is regarding pancreatitis associated TMA. This is another hot topic coming up, and
Okay.
which we are seeing left and right day-to-day life in the gastroenterology units. So those patients who get acute pancreatitis develops low hemoglobin, cystocytes in the peripheral smear, high LDH, thrombocytopenia. Are we supposed to wait, or do we go for the same treatment or the same protocol of TTP, set ADAMTS13 and initiate the plasmapheresis on seeing the cystocytes on the peripheral smear?
No, but I think that we can safely put it in infection-associated TTP. So in those patients, treating the root cause would be the ideal choice. Suppose a patient with acute pancreatitis has a very low platelet count and has bleeding event. In those patients, I would not hesitate to give platelet also in that particular patient. If ADAMTS13 activity is less than 10% in that patient, then only Plex will help. Otherwise, there is no role.
So it is must to set ADAMTS13 level for every
Yeah.
patient like this.
I think we should do it. It will, suppose even if we prevent one sitting of Plex, it is cost effective having to do
1 to 2
ADAMTS13.
Plex along with sending of ADAMTS13 levels.
Yeah, correct.
And if it is less than 10%, continue with Plex.
Continue with Plex.
Otherwise, stop it.
Yeah.
Fine. Stick and
we also like to do in some patient where there is a sort of a gray area between TTP and HUS, we straight away do a whole genome sequencing because it takes around 15-20 days. Better do it upfront rather than doing it later on if we are not finding anything. So one or two patients we had detected to have atypical HUS who presented like MAHA with less of a renal failure, but more of anemia.
Any role of plasmic score or French score in 2025?
If
Because
ADAMTS13 activity is not available, though it is available everywhere, because ultimately we can send it to KEM where they do it fraction of cost. So KEM, not KEM, but ICMR. It's in KEM building, Mumbai. So there they do it in 3000, but they take around 3 days of TAT. So if we do it in local lab, it should be available in a day or within 1 day or two. So less likely, but those patients, those area where the activity is not available, then it is still relevant.
Thank you. And last question was one person asked already on IVIG why it doesn't work.
Right.
I think the answer is very clear that IVIG is going to act on your antibodies. But in TTP, we are having 3 different mechanisms. One is large multimers of VWF. Second is the ADAMTS13 is going down and antibody against ADAMTS13. So even if your IVIG is acting on the antibody, what about large multimers? What about ADAMTS13? We are not replacing that. So I think that may be the reason why the IVIG alone is not sufficient for TTP because the 3 different mechanisms are there. So one mechanism only we are suppressing.
So maybe the ADAMTS13 endogenous production is not which can replenish the activity within couple of days. So we will not see the result.
Yes, absolutely. So we have to fulfill all the 3 things. The antibody production, number 1, replacement of ADAMTS13, as well as to remove the large multimers of VWF. So that can be. So anybody's any other question?
I just want to praise Dr. Rayani. The slides were very good. Especially the history slide, I was very happy. 1924, this thing happened. 1990, this thing happened. 2010, this happened. They're very representative. Even your pathophysiology slide was very, it was very just a interpret. One can easily understand the TTP. The complete TTP you can understand by your this pathophysiology slide. This.
Unfortunately, TTP is still not completely understood by even physicians, let alone surgeons and orthopedicians. They don't know anything about it, but even physicians, they also lack the knowledge. So, like some rare disease like TTP, we have to be comprehensive. Then only we can impart the knowledge. Yes,
when should we be suspicious of TTP so that we can start early?
Yeah.
So the physicians, they send our patients late. So they are transferred late. So that chunk of getting the treatment, basically the initial period is very important. Moment you move the 24 hours period, you are done with it. The problem is that.
Right.
So, well, so thank you so much, Dr. Ankit Rayani, and I thank all the delegates joining over here and all our discussions over here to participate in this webinar. Wonderful talk, wonderful discussion.